doses of AMI. Now, every patient that comes in here for an AMI may not be eligible for that aspirin because maybe they're allergic to it. So if they are, those particular patients would not be in that database. But this is for patients who actually are eligible to receive that aspirin. So what are our core measures? They're designed to ensure evidence-based practice for a specific patient population. Core measures are utilized by several external agencies, one of those being Joint Commission, and that is part of our accreditation, is making sure that we do our core measures, and also for Medicare and Medicaid. And I will tell you, in the past, core measures have been out since around 2000. And it has always been, through Joint Commission, is that we get paid based on reporting. But starting next year, it is going from reporting to performance. So that's going to be a big difference in how we're going to get paid. They're looking at performance now. They feel like we've had plenty of time, to get our processes in place. And so that's going to be a big difference. And so that's why it's so important that we nail down what we're doing with these core measures. So the core measures for inpatient, we're looking at AMI, we're looking at heart failure, we're looking at pneumonia, we're also looking at SCIP. And there's 5 diagnoses in this SCIP project that's patients who come in for hip and knee arthroplasties, patients who come in here for hysterectomies, patients who come in here for vascular procedures, and also colon procedures. We also do outpatients, and we look at patients who come in here with chest pain and AMI and certain surgical procedures. And there's nothing specific for outpatients. It's just a sampling of the outpatient procedures. So who benefits and who utilizes them? We've kind of talked about that a little bit. As I said, they are mandated by Joint Commission and CMS, and they also provide a measure of quality for our facility. How well are we doing for these patients? It also assures our community that our hospital is providing high quality care. It helps us gain accreditation. And again, as I mentioned earlier, it also helps us acquire our annual, what we call APU, and that's our annual payment from CMS. What we have to make on our core measure scores is 85% or greater next year. And to tell you, we really are doing a good job with that. And again, the core measures allows Joint Commission and CMS to compare how well we perform to other facilities across the country. It used to be, when they were first talking about how can we compare one hospital to another, back in the early 70s and 80s and in the 90s, they had no way, Joint Commission had no way of comparing hospitals, because at that time we all did our own process improvement, our own quality activities. But they wanted to see, how do hospitals compare? And so they started looking at what were the biggest diagnoses across the country. And the first one, of course, was patients who were admitted with AMI. So they started with that one, and also heart failure. And they looked to see how was practice being delivered across the country. The East Coast was certainly doing something different in their care based on the West Coast and the North and the South. So they looked at how they were practicing and who had the better outcomes. And then they trialed different things to see what was really giving them the best outcomes, what care. And that's kind of how the core measures really kind of grew from that. And so now they are able to compare one hospital to another. And of course, we have the public. They can go into the hospital compare. And I don't know if you've had an opportunity to do that, but you can go into hospitalcompare.gov, and you can see how the hospitals that surround us, how well we're doing compared to them. And really and truly, the public is really getting into finding the facility that they want to go to who gives the best care. So it's out there. And There's going to be a whole lot more information on that in the next couple of years. We're going to see physician performance. It's all coming. So let's talk about the first one, AMI. And the first measure is that, did that patient receive aspirin on arrival or within 24 hours of arrival? We know that when these patients come in through the ED, especially if they've been brought in by ambulance, a lot of times the EMTs will give that aspirin out in the field. But if they fail to do that, then that's something that the ED needs to do. But if they fail to do it, then we need to make sure up in the units that that patient gets that aspirin within that 24 hours. Making sure that they have aspirin prescribed at discharge, that they get an ACE or an ARB if they have a left ventricular systolic dysfunction, and that's usually for an ejection fraction less than 40. Adult smoking advice, and also beta blocker at discharge. So these are the things that we need to make sure when we're doing our medication reconciliation, that these medications are on that discharge instruction sheet. And making sure that a physician is documenting why he's not ordering maybe an ACE or a beta blocker or an ARB. So what is the rationale? Why do we give aspirin? Y'all know that. Why? Okay. During a heart attack, the blood vessels that normally supply the heart become blocked, and they're deprived, the muscle is deprived of oxygen. So chewing an aspirin early, in the early stages of heart attack, of course we know can increase blood flow to the heart and improve the chances of survival. Why do we give a beta blocker? Okay, it's to reduce the heart rate and decrease the force of heart contractions. That is correct. Our other core measure is congestive heart failure, and we do look at patients who come in here with a primary diagnosis as well as a secondary diagnosis of heart failure. Discharge instructions, there's 6 elements to that discharge instruction that have to be present when that patient goes home. We're looking at the activity, the diet, follow-up care, what medications have been prescribed for that patient, what are they to do for worsening symptoms, what are the worsening symptoms, and weight monitoring, very important on those heart failure patients. The second thing that we are abstracting is, did the physician do an evaluation of the heart for the left side of the heart? And if the physician has already documented what the ejection fraction is, he may not need to do another test, and so that's certainly okay. We're just needing what the function of the left side of the heart is. And again, did he order an ACE or an ARB if the ejection fraction is less than 40? And of course, smoking cessation. So our rationale for our ACE is what? I was a little quick there, so I'll give it to you. It's used to help the function of the left side of the heart because we know it's compromised. I'm sorry, go back just a second. And again, looking at ejection fraction less than 40. And we know that early treatment can reduce the risk of death from heart attacks. The other one, core measure, is our Surgical Care Improvement Project, or SCIP as we like to call it. We have one measure that has to do with beta blockers. Did that patient receive their beta blocker prior to admission who received a beta blocker during the perioperative period? Perioperative period is defined as 24 hours prior to surgical incision through discharge from PACU. They are given to reduce the risk of cardiovascular complications. So if that patient comes in and they've been taking a beta blocker at home, we want to make sure that they continue on that beta blocker because we do not want them to have any type of cardiac compromise during their procedure or after. Go back one. Okay.
Skip to that.
I will tell you that your slides may be just a little bit different too. After Tara had made the copies, I kind of went back and added some things and changed some things around. So again, you might see it a little bit different than what you have in your packet, but I did skip this one, so thank you very much. Skip one is prophylactic antibiotic that's administered 1 hour prior to incision, except vancomycin, and we know we have a two-way infusion time on that. INF2 is the appropriate antibiotic selection. Not every surgical procedure requires the same antibiotics. Patients who are going in for a colectomy, a colon surgery, their appropriate antibiotic is Ancef and Flagyl, unless they're allergic to one of those antibiotics. If they're going in for a hip or knee surgery, it's just Ancef. So it depends on the type of procedure as to what type of antibiotic they receive. Also, discontinuing those antibiotics within 24 hours after surgery in time, and that means when that wound is closed, those antibiotics should be discontinued within 24 hours. Now, we're talking about prophylactic antibiotics, okay? Not antibiotics the patient's on for an infection, because we have many patients, as you very well know, that go down for colon surgeries that are infected. So we're going to continue them on those antibiotics. This is just the prophylactic antibiotics. The new measure that has we've started looking at this past year, of course, is the urinary catheter. Making sure it's removed on post-op day 1 or post-op day 2, with day of surgery being 0. So making sure it's very important that we get those Foley catheters out. And the reason we want to do that is because the longer that catheter is in, the more chances that that patient has developing an infection. The other thing that we're looking at is a perioperative temperature. The core temps outside the normal range poses a risk for those patients who are undergoing surgery. Normal or body temperature recorded at 96.8 or greater within 30 minutes prior to or 15 minutes immediately after anesthesia in time must be documented. We need to know what that temperature is. One thing that surgery is doing, when the patients come into surgery, they check their temperature. If they're a little hypo or normothermic, they go ahead and put Bear Hugger on them, because we want those patients to have normal temperature during their procedure. And it's very important for us to know what that temperature was when that surgery is over. And I know a lot of times in the evenings, late at night, if you have emergency procedures, they're going to come directly to ICU for recovery. So it's very important that you get that temperature as soon as they get up into your area. Okay, we kind of talked about the first part there. Our VTE prophylaxis. Again, did the doctor order that VTE prophylaxis, and did we document that we applied the prophylaxis on those patients? Let's see, we kind of talked about that. Anesthesia does do our pre-op antibiotics. They've got a process down there, and we've talked about discontinuing the antibiotics. Pneumonia. Let's talk about pneumonia. There's several measures here. The pneumococcal vaccination, I know you're all aware of that one. Making sure that the blood cultures are performed 24 hours prior to or 24 hours after hospital arrival for those patients who are admitted to ICU. So we are looking at the blood cultures of those patients when they come into ICU. So very important that we make sure that those blood cultures are drawn. Also looking at the blood cultures in the ED when those patients come in. Smoking cessation, antibiotics within 6 hours of arrival. We want to make sure that we get them started on those antibiotics, and also the appropriate antibiotic. And of course the influenza vaccine. Pneumonia we give year-round, and the flu vaccine we give from October through March. So this is how we're performing now. This is data from July and August, and AMI, aspirin on arrival, we're at 100%. So we're doing a great job of making sure those patients are getting their aspirin. Statins prescribed at discharge. We had one patient that we failed to document on that discharge instruction sheet that they were to go home on a statin. Aspirin at discharge, 100%. We didn't have any patients who needed an ACE or ARB, so of course that's not in the database. Smoking cessation advised 100%. Beta blocker discharge 100%. So we really are doing really good. Our second quarter data for this, we were all 100% on everything. Okay. Heart failure discharge instructions 84%, and the one that's bringing us down on that is the medication reconciliation. And I am in the process of looking at medication reconciliation and hopefully we can get up to 90%. Right now, this is just heart failure patients, but I'm looking at every patient now to see how we're performing there. Left ventricular assessment, we have 100%. Those patients were put on an ACE and ARB. They had ejection fractions less than 40, so they got it, 100%. And of course, smoking, 100%. Pneumonia, blood cultures before the antibiotics for your ICU patients, we were at 100%, so great job on that. Smoking, 100%. Antibiotics, less than 6 hours, 98%. Making sure that they were on the appropriate antibiotic, 50%. So we have some work to do with our docs. It's just a matter of them ordering the appropriate antibiotics. So that's not a failure on your part, but we've got to work with our docs on that. And I'm hoping the new order sets will make a difference on that. We were in flu vaccine, so we have no data there. Prophylactic antibiotic within 1 hour prior to surgery, 100%. Ending in 24 hours, 87%. But what happens sometimes is, what I've seen is that when the patients come back from surgery, somehow the schedule gets off, and then that puts you past the 24 hours. So we've got to really be diligent in making sure we give those antibiotics on time and schedule. And antibiotic selection, 97%. Beta blockers, 100% on those patients. And I know that pre-assessment has done a great job on making sure that those patients take that medication. DVT, 98% physicians ordered it, and 95% documentation that they received it. So we have a little issue with documenting our VTE prophylaxis. Just want to let you know, we have some new core measure order sets, and they were approved last night at MEC. We thought they were approved a month ago, but there was some conflict on that. They took them back last night, and they have been officially approved now. So we have all new order sets. And the only thing they have to do, and they're in the back of the room, you might have already picked them up in your packets. The only thing they have left to do is put the logo on them and a place to put patient ID. So they should be out very soon. So be looking for those. All patients admitted to our facility now will have a general admit order set, which is also in your packet. So every patient will get a general admit order set. And the rationale for that is that the order set contains everything from a regulatory standpoint, so that if they come in here with heart failure, they're going to get a general admit order set and also a core measure set. And those core measure sets are not as lengthy and long because most of that stuff is in the general admit order set. Okay. So what's new in 2012? They are pulling the vaccines out of the pneumonia measure. Before, we were only looking at the vaccinations for patients who came in with a diagnosis of pneumonia. Well, that's changing now. They're going to look at every patient that comes in here to see if we have screened those patients, if they met the criteria, did we give that vaccination? So I'm not sure how they're going to pull all of that, but it's not going to be under the pneumonia measure set anymore. It's going to be any patient. Could be a patient coming in here for hip surgery, a hysterectomy. It doesn't matter. Any patient that's an inpatient. So we're really going to have to beef up how we're doing with those vaccinations to make sure that we're meeting the criteria. The new one coming up for AMI is looking at the LDL that's less than 100 milligrams per deciliter. And we're looking for documentation on that within the first 24 to 48 hours. And making sure that they are put on a statin if it's necessary. So that's a new AMI measure that's coming up in 2012. We're retiring the smoking cessation advice. So no longer will we have to extract data for that one. And the other one that's being retired is the initial antibiotic within 6 hours. They have felt that most hospitals have really met that. And so they said, no need to collect it. You're doing great. So those are the two that are being retired starting in 2012. The other information I wanted to provide you was the new DNR form, and that was in some of the information that you picked up at the back table. It has been revised, and it was approved at NBC. It has to go to the Forms Committee, but we've been instructed by Mr. Bass to go ahead and start using it. So that should be out on the intranet now. And any questions about that form? I know we're running out of time, and if there are any specific questions, if you want to get those to Tara, then I can get those answered and just send the answers back to you via Outlook, just because we are kind of running short on time. Any questions? I know it was just kind of a review for you, but is there any questions that I might can answer? Okay, if you think of something, just give them to Tara and she can get them to me. And thanks a lot for having me, and y'all have a great day.